Good evening, everyone. I would like to take this opportunity to welcome you back. Christmas and New Year break. And it's a great honor to welcome you back again to our usual AHA Nephrology Fireside Chat, Nephrology Education Webinar. Yeah, we are expecting to have some sort of changes a little bit. Will be some of the sessions will be accredited by Tanganyika Medical Council, and they'll be accredited for CPD points. So we'll be letting you know that in cases, I mean, all the sessions that will be accredited and that session that will be providing CPD points will be announced just before that day of presentation. And all the participants will be able to claim CPD points from your regulatory or your bodies, professional bodies. In Tanzania is from Tanganyika Medical Council. So today, today's topic is resistant hypertension, approach to management. And it's a great honor to introduce to you today's speaker, who is Dr. Ahmed Twahir, who is a specialist physician and nephrologist. He's a chair of Kenya Renal Association and the former senior lecturer, University of Nairobi. Dr. Twahir is also a clinical director of Parklands Kidney Center in Kenya. And is a fellow of International Society of Nephrology at the Guy's Hospital, London. So it's a great honor to welcome you, Professor Dr. Twahir. And I'd like to welcome you and start your presentation today. And the topic is resistant hypertension, approach to management. Dr. Twahir.
Thank you very much, Asante Sana. Want to thank Dr. Lloyd Vincent for inviting me to give this very important talk on the Fireside Chat series. And this one will be number 67. Also want to congratulate him and his team for organizing such an important event. And this is the first one this year. So Dr. Lloyd, I hope you will continue with this very important event with your team, and we'll be there to support you. So this evening, I want to give a talk on a very important topic called resistant hypertension, approach and management. And we are all, most of us are in the renal field. We see a lot of people with very difficult hypertension, and sometimes we're stuck in what to do. So this evening, we'll go through a systematic way of managing these patients. I hope you can all hear me loud and clear.
Yes, clear, very clear.
Okay, thank you very much. If there's any, this will be a very informal talk. Feel free to interrupt.
Yes.
I'm moving too fast. Please let me know. I will slow down. So good. So let's start with epidemiology of hypertension. This will be a reminder for all of you just to start off the talk. Hypertension has a very high prevalence, affecting 1 in 3 adults. As it is, this is number one chronic disease worldwide, affecting 1 billion people. And in the year 2025, we expect it to affect 1.6 billion people. It is the single largest contributor of death worldwide. And for every rise of 20 to 10 millimeters of mercury systolic over diastolic results in doubling of 10-year cardiovascular mortality. Hypertension dramatically increases risk of heart attack, heart failure, and kidney failure, and only half of all treated patients are controlled to established blood pressure targets. So as I've said, high blood pressure benefits the reduction of reducing the benefits of reducing BP. It results in heart failure improvement, reduction in stroke, reduction in coronary heart diseases, reduction in vascular death, and what's not added here is reduction in progression to chronic kidney disease and end-stage renal disease. So what about treating resistant hypertension? Is there any evidence to show that treating resistant hypertension is beneficial? So there are many studies that have shown that patients with resistant hypertension are at higher risk for poor outcomes compared with patients without resistant hypertension. In one study I found from Kidney International, I think 2015, which was looking at over 400,000 patients, compared patients without resistant hypertension and patients with resistant hypertension, and found a 32% increased risk of developing end-stage renal disease, 24% increased risk of ischemic heart event, and 46% increased risk of heart failure, a 14% increased risk of stroke, and a 6% increased risk of death. So these studies suggest that resistant hypertension is associated with an increased risk of adverse outcomes and represents an important public health problem. So it's not something we should take lightly. Clearly, this is not a benign condition that we're dealing with. This is an article in Kidney International 2015, those of you who are interested. And the title was Comparative Risk of Renal, Cardiovascular and Mortality Outcomes in Chronic, in Controlled and Controlled Resistant and Non-Resistant Hypertension. And they concluded that the risk of end-stage renal disease and cardiovascular events were 25 and 23% greater, respectively, in untreated hypertension and those with untreated resistant hypertension compared with controlled resistant hypertension, supporting the linkage between blood pressure outcomes and both these outcomes, that is renal failure and cardiovascular events. So when we talk about resistant hypertension, what do we mean? We'll go through a few definitions so that we can get what this is all about. So in 2018, the American Heart Association and the ACC in their 2018 guidelines, and together with the ESC and European Society of Hypertension, made a statement. And they said that blood pressure that remains above goal in spite of concurrent use of 3 antihypertensive agents of different classes will result in resistant hypertension. However, the following caveats will remain. If tolerated, also one of the 3 agents should be a diuretic, and all agents should be prescribed at maximum recommended doses or maximum tolerated doses. And patients whose blood pressure is controlled, but they're using more of 4 or more antihypertensive medication, will also be considered as resistant hypertension. And I'm sure in the back of your minds, you are seeing this patient who comes to your clinic with more than 3 drugs and their blood pressures are not well controlled. And you're wondering, what should I do? So if we look at further epidemiology of resistant hypertension, people with hypertension, 30% will be untreated, 35% will be treated and controlled. Now, the ones that we're after for this evening's talk are the 35% that are either true resistant, refractory, or pseudo-resistant. I'll give you an example of this is a case history of a patient, Mr. Khamis Kombo. We'll call him KK. He's 58 years old. He's been diabetic for 4 years and he's been hypertensive for 20 years. His body mass index is 28.2. He's currently on losartan hydrochlorothiazide combination at 100 milligrams and 25 milligrams respectively. He's on amlodipine 10 and is on metformin 850 BD for his blood diabetes. His blood pressure in the clinic today was 144/94. And this was taken standardized technique. I'm going to describe what that means as opposed to routine blood pressure technique. His physical examination is unremarkable. His kidney functions are normal. His potassium is good at 4.2. His HbA1c is good at 6.6. His ECG shows normal sinus rhythm, but with voltage criteria of left ventricular hypertrophy. So the the question is, does he have resistant hypertension? So if we look at the definition, they need to be on 3 antihypertensive drugs at maximum or maximum tolerated doses, and one of them is a diuretic. So this patient clearly fits the criteria because he's on losartan 100, hydrochlorothiazide 25, and amlodipine 10. And his BP is not at target. Okay, here's another common example of a common patient. Mrs. Ann Kamau is 62 years old. She's been hypertensive for 10 years. Her blood pressure in the clinic is 160 over 105. I'm sure you'll recall one of these type of patients who has entered your clinic recently. And she's on amlodipine, enalapril, methyl-dopa. So the question is, does she have resistant hypertension? And I want to bring out the point that if you don't know the dosage of the drug the patient is on, or the patient is not on maximum tolerated doses, then you cannot call it resistant hypertension. So at this stage, the only thing we can say is this is apparent resistant hypertension. Could be resistant, could be pseudo-resistant. So we'll see in the following slides what those two things mean. So what is true resistant hypertension? So I'm going to go through this because it's very important that we understand the meaning of this so that we can manage our patients effectively. So blood pressure that remains above goal in spite of different concurrent use of 3 antihypertensive agents of different classes after excluding pseudo-resistance, which I'm going to describe. And you can see the word goal, I've underlined it and put it in red. It's because what is the goal? I can ask all of you in the audience, what is the target blood pressure? And I'm sure half of you will give me one number and the other half will give me another number. And I wouldn't be surprised because, as you know, the target blood pressure goalpost, as so to speak, has been shifting over the years. And you'll see even until now, people have not yet come to a consensus what our target goal blood pressure should be. Anyway, for this evening's talk, the emphasis is the patient who comes to your clinic and has got difficult to treat hypertension, as what I've described before. So if the patient is tolerating the 3 drugs well and is on maximum tolerated doses, and as I said earlier, even if they're on 4 drugs, but and they're well controlled, you'll still call them resistant hypertension. Now, there's an entity called refractory hypertension, and these are patients who are on 5 drugs, including chlorthalidone and a mineralocorticoid receptor antagonist like spironolactone, and still their blood pressures are not controlled. So this is what is called refractory hypertension. So I said I will explain to you what is pseudo-resistant hypertension. So pseudo-resistant refers to poorly controlled hypertension that appears resistant to treatment, but is actually attributable to other factors. Now, what are these factors? I've listed some of them here. I'll go through them very quickly. Inaccurate measurement of blood pressure, poor adherence to antihypertensive therapy, suboptimal antihypertensive therapy, poor adherence to lifestyle and dietary approaches to lower blood pressure, such as reduced sodium intake, white coat hypertension, other drugs and other substances that may affect blood pressure control. So if your patient does have these things which I've mentioned, then this is not true hypertension, true resistant hypertension. This is pseudo-resistant hypertension. So let's look what is inaccurate measurement of blood pressure. Now, it's important that I go through this because this has been the backbone of the current, most of the current guidelines are emphasizing on blood pressure techniques. And many of them following this technique of measuring blood pressure have actually adjusted the target blood pressure measurements. Indeed, major studies like the SPRINT study and ACCORD studies used exactly this technique that I'm talking about, and this has now been called the standardized blood pressure technique. And if you don't follow this, then you'll term your blood pressure measurement as routine blood pressure measurement. So let's go through this quickly. So number one, the patient must be relaxed, sitting in a chair, feet on the floor, and they need to have relaxed for at least 5 minutes. The patient should avoid caffeine, exercise, and smoking for at least 30 minutes. Ensure patient has emptied their bladder. Neither the patient nor the observer should talk during the rest period or during the measurement. Remove all clothing around the arm where the cuff will be. Measurements made while the patient is sitting or lying on the examining table do not fulfill the criteria. So the patient must be sitting with their feet on the ground. Support the patient's arm or rest it on the desk. Position in the middle of the cuff on the patient's upper arm at the level of the right atrium or midpoint of the sternum, and then use the correct cuff size. So that is very, very important. And as you see, this is a picture of the way your blood pressure should be measured in the clinic. Okay, so what about poor adherence to antihypertensive therapy? What contributes to this? So pill burden. A lot of our patients, not only are they taking antihypertensive, they're also on antidiabetics and antiplatelets and drugs for cholesterol. So clearly, this becomes a discouragement for them to comply with their medication. Affordability. It's very important that when you're prescribing your antihypertensives, you must make sure that your patient can afford. It's not important just to write the prescription. You need to find out whether this is affordable to the patient. A lot of patients forget, especially the elderly patients. So we need to talk to the family members to help the patient's compliance. Another very important thing that will contribute to poor adherence is the side effects of the medication. A lot of men come telling me that that medicine for blood pressure is causing erectile dysfunction and he doesn't want it, he wants to be changed. So clearly he's not going to take it. And the challenge is here is most of the blood pressure medications will actually cause that. So it's very important that you sit down with the patient and tell them, and this is what I do, I tell them, for now, your health is more important than your sex life. So let's focus on your health. And then at one time or another, we'll sit down and discuss options to improve your erectile dysfunction. So leg edema, this is quite common in women. Women, when they get even slight leg edema, especially from calcium channel blockers, they'll tell you, I don't want this medication. And cough, and especially with ACE inhibitors, this is something about 10 to 20% of patients on ACE will develop a cough. And I've said the solution is to spend time with the patient, talk with their families. And something that is so useful is to tell the patient to come with their medication to the clinic. Spend time with your patient, looking at the containers, at the boxes, to make sure that what they're taking is what has been prescribed. Okay, what about suboptimal antihypertensive therapy? So a lot of this is actually related to us doctors. Most of the time, we are not sure whether to increase the medication, to leave it, or to say maybe this is just a white coat effect. So you actually need to be very proactive, and if you feel your patient is not reaching your target, then you have to increase to the maximum tolerated doses. Another problem is the use of diuretics. It's very important before you decide that this patient has resistant hypertension to make sure that they're on a good diuretic. And I say good diuretic because it's coming out quite clearly that chlorthalidone is a better diuretic than hydrochlorothiazide, or indapamide is a better a diuretic than hydrochlorothiazide or bendroflumethiazide. So these are the thiazide-like diuretics. And clearly, if your patient is still not responding, addition of a mineralocorticoid receptor antagonist like spironolactone has been shown to greatly improve the blood pressure control. So what about poor adherence to lifestyle and dietary approaches and example, reduced sodium intake? So it's very important that you talk to your patient to reduce the sodium intake. Sometimes this may be very difficult, but what is easy, just tell them don't add any salt when you're eating, and also if the one who cooks has come is to the clinic, mainly when the husband comes with the wife, it becomes easier because you tell her not to add too much salt. Again, so how do we know that this patient is taking too much salt? Because this is very subjective, telling them not to take too much salt. If you're not sure, if you measure the 24-hour urine measurement or even a spot urine for sodium, anything more than 100 millimoles per liter is suggestive that they're taking excess sodium chloride. Another issue is obesity. It's very important to counsel your patients on weight loss reduction techniques. Sedentary lifestyle. It's very important to advise your patient to exercise at least a total of 150 minutes in a week total. This has been shown to be useful. Avoidance of herbal medications and excessive alcohol. So what is white coat hypertension? I've said clearly, white coat hypertension contributes to pseudo-resistance, but what is white coat hypertension? So one thing that was discovered, and this is a slide I picked up from Up to Date, that the presence of the doctor in the room can raise the blood pressure by up to 22 millimeters of mercury. However, this tends to settle down with time, and this tends to be repeated even over the next 3 to 4 days until the patient gets used to the doctor. And the nurses are not exempted, because you can also see that there is a rise in blood pressure even when the nurse is in the room. And that is why some people opted for, when they're doing automatic blood pressure measurements, to have either nobody in the room and the blood pressure machine actually is doing everything. Actually, those machines that are available, and this may reduce the white coat effect. So how do you start suspecting that your patient might be having white coat hypertension? When they're in the clinic, their blood pressure is high, but they tell you that when they measure at home, their blood pressure is normal or even low. And these are patients who start feeling dizzy at home because the blood pressures are lowish. So these are patients that you need to either do ambulatory blood pressure monitoring, or if you don't have a ambulatory blood pressure monitoring, there are techniques you can teach them on doing home blood pressure monitoring. So another aspect that contributes to pseudo-resistance are drugs and other substances. Very quickly, I'll go through them. Oral contraceptives, antidepressants, steroids, decongestants, even these nasal decongestants. You need to be very careful when your patient is hypertensive and you're wondering, how come the blood pressure is not coming down? Think of nasal decongestants. Weight loss medication has been shown, sodium-containing antacids, erythropoietin, calcineurin inhibitors, cocaine, other stimulants like amphetamines, typical antipsychotics. A common one is olanzapine. There's a anti-cancer drug like bevacizumab, tyrosine kinase inhibitors, again, sunitinib, and licorice-containing products. So this is magazine time. I just showed this to highlight what is the currently recommended goal blood pressure. And it's so confusing, because if you look at so many different associations have come up with so many different targets. Clearly there's a 130-80, there's a 140-90, and there's a 120-80. If you look at KDIGO, because we are nephrologists, it's important to appreciate what our association is recommending, and they're recommending 120/80. Now, this only applies if you're doing a standardized office blood pressure measurement technique. And I said standardized, you must follow those guidelines very strictly, the ones I've highlighted. And if you're not able to follow those guidelines, then don't target this number, otherwise you might cause hypotension in your patient. So patients with resistant hypertension are more likely to have an identifiable cause of hypertension. Now, the beauty of going through this stepwise approach is that you can, it teaches you how to pick up other causes of hypertension that can be managed, and these are secondary causes. So now you've reached this stage, and you're sure this is not pseudo hypertension or pseudo-resistant hypertension. This is true hypertension. Now, what goes on in your mind? Is this patient having obstructive sleep apnea? Is it a renal parenchymal disease without primary hyperaldosteronism? Is it renal artery stenosis, or more uncommonly, FIO, Cushing's hyperparathyroidism, or coarctation? So your thought process begins to start working, and you start remembering your medicine, and you start saying, somebody who has severe or resistant hypertension is likely to have secondary hypertension and acute rise of blood pressure. If somebody has hypertension before puberty, that is very unusual. So you start thinking of secondary causes of, especially when you see a female before puberty, think of fibromuscular dysplasia, and especially this is amenable to surgical intervention. If you see somebody with age less than 30 years old, no family history of hypertension, not obesity, think of secondary causes of hypertension. Other causes of hypertension are renovascular hypertension, renal artery stenosis. It's very important to have this as your differential, because the management is very difficult, as I'm going to highlight. So primary kidney disease, this is easy. This is bread and butter in nephrology. Most of our patients have elevated serum creatinine due to some sort of kidney disease. There are other causes, FIO, primary hyperaldosteronism, Cushing's, as I've mentioned, sleep apnea, coarctation, hypothyroidism, and hyperparathyroidism. Look at this slide. It just highlights that primary hyperaldosteronism is such an important cause of resistant hypertension. In a study done that was appeared in the American Journal of Kidney Disease in 2001, showed that in different areas, like in Seattle, 17% of the patients had primary hyperaldosteronism to explain their resistant hypertension. And this varied to about 20, 22, and 19% in other areas. So it's important to realize this is an important cause, because use of an mineralocorticoid receptor antagonist usually solves your problem. Pheochromocytoma, we've talked about that. This patient will usually have episodic hypertension, palpitations, diaphoresis, or tremors. And measuring urinary metanephrines, or even very easy, simple serum-free metanephrines as a screening tool will be able to identify patients who have FIO. And we talked about renal artery stenosis. So what do we do with patients with renal artery stenosis? Clearly, I said if they're young and you're diagnosed to have fibromuscular dysplasia, there's a benefit of stenting. However, patients with atherosclerotic renovascular disease, these are usually adults, mainly diabetic, they have renal artery stenosis. Clearly, the data is not convincing whether you need to stent them, and several studies, including the latest, the CORAL study, the Astral, the DRASTIC study, showed that if you were able to treat them medically and control their blood pressures, then they had the same outcomes as if you stented them. And the problem with stenting, they found in this study, is that you may cause cholesterol embolization peripherally, and even worsen the kidney function and develop an acute kidney injury. So clearly, the use of stenting in adult patients with renal artery stenosis is an important issue. The only time that it might be allowed is if the patient comes with flash pulmonary edema, or you're having progressively deteriorating renal function, then you might try to stent them and see whether you might be able to stop this. So what about pharmacological treatment? So this is important, because this is where the challenge is. So by the time you have your patient, you've diagnosed them with resistant hypertension, They're already on 3 drugs. Remember, we said that in our definition. So at this stage, when we're looking at this slide, our patient is already on 3 drugs. They're on a long-acting calcium channel blocker. They're on a RAS blocker, either an ACE inhibitor or an A2 receptor blocker, and they're on a diuretic. You've already done the lifestyle interventions like weight loss, exercise, low salt diet, and so what do you do next? So your patient is still not at goal. Then you need to substitute your diuretic. Let's say they're on a hydrochlorothiazide or benzoflumethiazide. Then clearly data has shown that chlorthalidone or indapamide is a much better thiazide diuretic than hydrochlorothiazide. So change them and you'll be surprised your blood pressure will improve. And if not, then we move to step 3. So in step 3, the patient is still not at goal. You add a mineralocorticoid antagonist like spironolactone. Spironolactone is there, it's cheap. Side effects are gynecomastia, and clearly, if this is a major issue, you can try epirinon. It has less side effects, although less effect on blood pressure control. If still your patient is not at target, then you need to think of beta blockers like metoprolol, labetalol, carvedilol. And if still your patient is not at target, then you need to think of hydralazine. And if still your patient is not at target, then although this study, this algorithm talks about minoxidil, in my private practice, I found an amazing drug, clonidine. Clonidine is very good for patients with resistant hypertension. The only problem is you cannot withdraw it suddenly because you get a rebound hypertension. So remember, your patient on clonidine, if you need to withdraw it, you need to taper it off very slowly. Minoxidil is a very powerful antihypertensive vasodilator agent, and it's last because it's expensive, and also when I used it, I found one of my patients developed a pericardial effusion, and when I looked at the literature, I found it was a non-complication. One of my patients who did very well on it, unfortunately, she was a female. She developed hirsutism, and she demanded for me to withdraw it, and it was very difficult because that was the only drug that seemed to work in her. So coming to the last slide, what other strategies do we have? We've talked about renal artery stenting and the pros and cons, but show clearly it's beneficial in young people with fibromuscular dysplasia. Other strategies that are still experimental, I would say, is electrical baroreceptor stimulation. Renal denervation is still undergoing its ups and downs because in the Simplicity 1 and Simplicity 2 trial showed clear benefit, but these were observational studies. And then in the Simplicity 3 trial, they showed no benefit, but the argument was the technique was wrong. But there are more studies that are coming out that might show good outcomes with renal denervation. Clearly, surgical bilateral nephrectomy has been shown to improve blood pressure, especially in patients with polycystic kidney diseases who are on dialysis, and you find their blood pressure very difficult to control. One interesting strategy that I found in reading the literature is that creation of an AV fistula in some centers have been tried to, and shown that they're beneficial in terms of reducing in patients with resistant hypertension. So I've taken 40 minutes. Thank you very much for your attention. I'll be happy to take any questions.
All right. Thank you very much. That was a very exciting presentation, excellent presentation, Dr. Ahmed Twahir. So it's a time for questions, but Dr. Twahir, I would like to ask you one question. You know, you have covered a very important topic, especially in patients who are on dialysis. And most of these patients, they have resistant hypertension. And you would find that most of them, they are using more than 3 to 4 drugs to control their hypertension. And therefore, my question is it necessary that we treat our patients using the algorithm that you presented in this presentation? Because I would think that some patients comes with particular complications that probably if you use the algorithm that you presented, it won't be of benefit to the patient. For example, some patients might be presenting with tachycardia, for example, and therefore you would like to start with beta blockers instead of other following the algorithm that you presented. So do you think that is we should all follow that one, or it depends with circumstances and the type of patient that you have? That's number one. Number two is salt reduction. This is very difficult to tell the patient that you should reduce salt to a particular amount. 2 grams is a very small amount of salt, and therefore quantifying, and in our culture in Africa, we normally don't measure the quantity of salt that our people take, or even ourselves take. So it's very difficult. And some of the food contains a lot of salt. For example, the normal bread contains a high amount of salt. For those who are coming from the coast, those fried fish contain a lot of salt. So, and some other kind of foods also contain a high amount of salt. So I find it very difficult. Maybe you should, can you please give me the, your experience? How do you normally advise patients on salt reduction? Thank you, Dr. Twahir.
Okay, so for the algorithm, remember this is your patient with resistant hypertension, and true, they may have compelling indications like heart failure. So I said clearly, if they have compelling indications like heart failure, you will want to introduce a beta blocker earlier. So remember, this patient is already on an ARB, is on a calcium channel blocker, and is on a diuretic. His hypertensive blood pressure is, let's say, 150/100, and they have heart failure. So clearly, you want to introduce a beta blocker. A good one is carvedilol. And if they have a tachycardia, obviously you want to introduce a beta blocker. So yes, it's important to follow the algorithm. And if you have compelling indications, you can break away from the algorithm, but at least the algorithm gives you the options that you have available. And obviously these are guidelines. So you as an individual, you can say, for this patient, I'm not going to follow this algorithm. So very quickly, I'm going to go through them again. Your patient is already on your triple agents, maximum tolerated doses, and then still blood pressures not controlled. So what option do you have? I said use a thiazide diuretic or thiazide-like diuretic like indapamide and or clothalidone. Now your patient has heart failure. Clearly, you're going to say Lasix is got a better diuretic effect than these two. So I'm going to use furosemide. And then clearly your patient has not improved. Then you go to spironolactone. So, and this is what I'm trying to get to. You need to follow a systematic approach so you don't get confused. Many of us are managing patients suboptimally because we get tired, we give up along the way. So I've given you a very nice approach to manage these patients so that you can effectively control their blood pressure. And the issue of salt is very important. As you said, many of us tell our patients, reduce the salt in your food, but we don't tell them how to do it, number one. And even those who tell them, okay, don't add extra salt in your food. Maybe in the kitchen, the wife has already added too much salt in the food. So how can you tell that this patient is taking more salt than, as I said, measure the, as we said, the maximum you're allowed is 2 grams of sodium or 5 grams of sodium chloride. So now 2 grams of sodium is about 100 millimoles. So if you can make sure that your urinary sodium is less than 100 millimoles, then clearly you've achieved your target. But I can tell you, this is a very unpalatable food. So you need to guide your patient and their family to add spices to help improve the taste of the food. And the importance of low salt is so important because it can help reduce your blood pressure by as much as 10 to 15 millimeters of mercury. So don't underestimate this very important technique, which is free. You don't need to pay anything to reduce your salt intake. Next question.
All right, thank you. Yeah.
Dr. Twahir, you raised somewhat I think is actually very important, the arteriovenous fistula as far as reduction of hypertension is concerned. You know, I starting imagining the mechanism. Yes, systolic pressure seems that to be possible. It can reduce it. But does it reduce systemic pressure? I mean, systolic pressure and diastolic pressure equally? I mean, to the same extent. And what is? I mean, what is the mechanism for systolic pressure is clear to me, but I don't understand how it would reduce diastolic pressure.
This will is obviously the technique is reducing your afterload, and clearly there are drugs that reduce afterload and are very useful in reducing your blood pressure. But again, you know that AV fistulas in our dialysis patients, although we prefer them to catheters, they may not be free of side effects, especially if you have a fistula that has a very high output, can be associated with high cardiac output failure. So although this is a strategy that has been mentioned, clearly I don't see it taking off very well because of its accompanying complications. But when you're desperate, and you know many times you have been desperate and you're looking for a strategy, this might actually be a strategy you can try with the limitations that you have highlighted yourself.
Thank you.
Thank you, Dr. Twahir. We are continuing to receive some questions. Other questions?
Hello, Makwabwe.
Yeah, oh, Professor, Dr. Rugajo.
Okay, thank you so much, Dr. Twahir, for a very fine exposition on resistant hypertension, which is usually very stubborn. For patients on dialysis, sometimes as a desperate measure, we have to lower the sodium level in the concentrate, probably hovering between the standard of 138 to 135 and at times to 130. This is a practice, but there are no clear guidelines. So what are your views on this and experience?
Okay, that's a very good question, but the management of hypertension in dialysis patients is a very difficult topic and really needs a session on its own. However, I'll be very brief. There are several strategies. One you've mentioned is to lower the sodium. We did a study at the Aga Khan Hospital where we randomized patients, and this was to 138, 135 in the sodium concentrations on the machine. And we found that there was no difference in their blood pressures control. And this was a crossover study where the patient acted as their own controls. So clearly, although our study was small, so in our study, there was no major difference in terms of improving blood pressure control by reducing the sodium concentration on the machine. However, other strategies clearly giving your patients 3 sessions a week, ultrafiltrating them to their dry weight. Now, most people, when they start ultrafiltrating, they think that the benefits of that will appear within 3 or 4 days of dialyzing your patient. You need to be very patient. It takes at least a month to improve blood pressure control using ultrafiltration to dry weight techniques. And this was very well shown in the FISN study in France, where they were doing daily dialysis as opposed to the standard alternate day dialysis. And they found that more than 90% of their patients who were on daily dialysis were actually off their antihypertensive medication. So clearly, if you are able to dialyze your patients well, take them to their dry weight, cut down on their salt, this is a strategy that can help improve your patients' blood pressure. I see patients coming to me saying that they're dialyzing twice a week. Their intradialytic weight gain is more than 4 liters. And then they complain and tell me that my blood pressure is too high. What are we going to do about it? So I tell them, first of all, you need to reduce your water intake. You need to increase your sessions of dialysis, and you need to aim for appropriate dry weight. And I have a bioimpedance machine that guides me into their dry weight. And despite that, I still have patients with very difficult blood pressures to control. But this is not unusual. Even if you look at the literature in the West, many centers find it very difficult. And up to now, we've not really defined what is the ideal blood pressure in a dialysis patient. Should we measure the pressures at home? Should we measure the pressures before dialysis? Should we measure the pressures intra-dialysis or after dialysis? Clearly, there are no very good control studies to answer these questions. So I'm afraid your very good question doesn't have a very good answer.
Yeah, I have seen the hand of John Ngobi. Gombi.
Yes, thank you so much, Dr. Twahir, for your very nice presentation. My question is about the SGLT2 inhibitors. Looking at, we're talking about the sodium and reviewing the recent evidence that they have a good benefit in the renal and cardiovascular diseases. Do we have any chance to use them in the resistant hypertension?
Okay, good question. And I actually looked into that because I knew somebody would ask that question. And I found out that yes, the SGL2 receptor blockers might be able to reduce your blood pressure by as much as 5 to 10 millimeters of mercury. So in the algorithm, you can actually find a place to fix it there. The only problem is many of our patients already have a low GFR, as you are aware. So, and there's really no data in SGL2 below a GFR of 20, but clearly if your patient has got a GFR of more than 30, this is another trick you might try to use.
Thank you so much.
Thank you. Any other comment or question? Dr. Twahir, can you read from the chat box?
I can read.
Yeah. Okay,
Yeah.
well, let me see. Thanks a lot for you. I have seen lots of patients who are having resist, but when we started them on methyl-dopa, their blood pressure became well controlled. What is your experience on methyl-dopa? Okay, good question. Methyl-dopa is a time-tested antihypertensive agent. It's been there since I was in high school, and it's still being used. And currently, I reserve methyl-dopa mainly for pregnant patients or when a patient has resistant hypertension, not as a first line. Clearly, when you're treating hypertension, it's not just about lowering blood pressure, but it's about achieving target end organ benefit. So if you lower your blood pressure with Aldomet, as compared you lower your blood pressure with telmisartan, will you still get a beneficial left ventricular improvement with Aldomet as much as you will with telmisartan? Clearly no. So yes, methyl-dopa may lower your blood pressure, but in terms of end organ benefit, you might not get. So at the end of the day, it's not going to be your first line antihypertensive agent. And if you look at the algorithm, it has its place somewhere much lower in the cascade. So coming back, can you help us to share then the view? So yeah, I'm not seeing any more questions on the chat unless you have some.
Yeah, I think that's all we have on the chat box. So, Dr. Lloyd, you have a question, comment?
I think Dr. Twahir is extensively covered. I don't think I can ask any question. It's a wonderful presentation, and in 40 minutes cover the whole of resistant hypertension, everything without a gap. So thank you, Dr. Twahir. It is a wonderful, exposition of this topic, and it's full house. And I'm sorry that we couldn't allow everybody on board because we had 100 as the target. I mean, 100 as the upper limit. But now I think we'll have to open up and a lot more people. Because I think we about 15 people could not get into the system. Apologies for that. It's a wonderful session. Thank you so much for this.
Thank you, Dr. Lloyd. Dr. Twahir, one last question from my side. You mentioned it clearly that some people compliance would be affected by the side effects of antihypertensives, and one of the biggest problems, especially from our side in East Africa and Africa, of course, is erectile impotence, and some patients has been having a myth that there are some antihypertensives which are better, and in terms of affecting the erectile impotence to some of our patients. Do you know that there are some antihypertensives which are better, they don't have that side effects, and some of them which are worse on that?
Okay, good question. I think all antihypertensives will have an issue with erectile dysfunction, but some will be more than others. And really, the objective is to treat the blood pressure and look for other options of improving the erectile dysfunction. So what I do in many of my patients who will develop this, I'll usually put them on Targentis, either 5 milligrams or maybe the PRN regime. So it's a major concern, but you need to address it by treating the problem, not avoiding the medication. So even drugs like telmisartan or the ARBs and which have been shown to have less erectile dysfunction, you'll still find some patients complaining of the same when they are on this ARBs. And remember, a lot of our patients are also diabetic patients. So you might attribute your erectile dysfunction to the hypertension, but actually it's as a complication of the diabetic complications. And again, focus on your blood pressure first. As I gave an example of my patient, I tell them your health comes first, but we'll address your sexual aspect by looking for alternatives to help you with your erectile dysfunction.
Thank you, Dr. Twahir. I will allow one more question before we end our session today. Dr. Twahir, that was excellent presentation. The topic that we almost every day when we see our patients as nephrologists and physicians, we normally see patients with hypertension. So you have touched a very, very important topic, and the presentation was super. Thank you very much, Dr. Twahir, and we would like to welcome you once again next time when we request you to come and share your knowledge with us.
Thank you. Thank you very much.
Thank you.
Yeah,
Thank you so much.
I would also like to thank every one of you who attended. And as I said at the beginning, starting from next week, if all things goes as planned, we'll start awarding CPD points. So get prepared to claim your CPD points after attending sessions. Dr. Lloyd, final.
No, I have no words to say. Thank you to Dr. Twahir, and I'm sure that now we would work together across the board in East Africa to make sure that everyone contributes and to disseminate the state of the art in nephrology. Thank you very much, Dr. Twahir.
All right, thank you, and see you next week.